Our next speaker is Sonja Baldursdottir. And Sonja, please come to the floor. Sonja is a neonatologist working here in Stockholm at Karolinska Hospital University. And you will tell us something about stabilization respiratory support in the delivery room.
Yes.
Yes, please go ahead.
So, good afternoon, everyone. And thank you so much for the invitation. It's been very inspiring to listen to all the previous talks. And after listening to Ulla's talk, we know all about the transition from the fetal to neonatal circulation and the benefits of delayed or preferably physiological cord clamping. And it's not only important after how many seconds or minutes the cord is clamped, but as you were saying, it's also important that the lungs get aerated during this time. And in the full-term baby, this usually happens without our help being needed, while the preterm infants usually need some respiratory support after birth. And that will be the focus of my talk. In many hospitals, this has been and still often is the scenario when a baby needs respiratory support after birth. The cord is cut and the baby is brought to the resuscitation table where the respiratory support is started. And we can see there are lots of hands, all are with gloves, and probably none of them are the hands of the parents. So much rather, we would like it to look more like this, with the infants still close to the parents and receiving respiratory support. So it's ideal not only to keep the cord intact, but also to keep the family intact. And that is in line with the new World Health Organization recommendations on the care of the preterm and low birth weight infant. And among the interventions that are recommended are, as you know, the kangaroo mother care and also the continuous positive airway pressure. And if you take a closer look, we can read that kangaroo mother care for preterm or low birth weight infants should be started as soon as possible after birth. And also that continuous positive airway pressure therapy may be considered immediately after birth for very preterm infants that are born below 32 weeks gestation with or without respiratory distress. So how can we be better at combining these interventions? And these are questions that I think have been one of the obstacles. We have been wondering what is known about the effect of skin-to-skin on respiratory stability, and is skin-to-skin safe for preterm infants that are receiving respiratory support? And there have been some studies that have been addressing these questions during the last few years. We have heard about some of them. I would like to mention first the study by Niels and colleagues. They randomized 100 low birth weight infants with a birth weight of 1,500 to 2,500 grams to either routine care in an incubator or skin-to-skin contact after birth. And they measured the script score that we have heard all about. And they found that infants in skin-to-skin contact had higher script score at 6 hours and concluded that skin-to-skin contact is likely the optimal environment for low birth weight neonates without life-threatening conditions. And this study was conducted in Australia, where 40 preterm infants with a mean gestational age of 27.6 weeks that were receiving respiratory support with either mechanical ventilation, CPAP, or high-flow nasal cannula were studied on day 5 to 18. And they measured regional cerebral oxygenation using NIRS during both skin-to-skin contact and in an incubator. And each infant acted as its own control. And they found that cerebral oxygenation and other physiological measurements did not differ between skin-to-skin contact and incubator care. Another study, this one conducted in Finland, 17 preterm infants that were born before 36 weeks gestation, receiving respiratory support with invasive or non-invasive NAVA. They were studied, and respiratory variables during 167 episodes of skin-to-skin care were compared with matched control periods during incubator care. And they found that during skin-to-skin contact, infants had reduced work of breathing and less need for backup ventilation compared to during incubator care. And then, of course, we have the immediate skin-to-skin study, and we have already heard about this study, which showed the beneficial effects of skin-to-skin contact immediately after birth on the cardiorespiratory stability. And I think we can summarize these studies by saying that skin-to-skin contact for a very preterm infants has either showed equal stability or improved respiratory stability compared to incubator care. Yes. So the routine care in our unit has previously been to use the TPs with a face mask if the infant has inadequate breathing after birth. However, we know that mask ventilation is often complicated by airway obstruction and leakage, and also the mask placement may induce apnea by the trigeminal cardiac reflex. And therefore, we change to the nasal CPAP when the baby is breathing stably. But could this be done in any other way? Yes. So the RPAP system is a new resuscitation system that was developed in Sweden, and it was first evaluated in a mechanical lung model and clinical feasibility study in preterm infants. And tests in the mechanical lung model showed that the system is pressure stable and has lower imposed work of breathing compared to conventional TP systems. And this can be visualized with a pressure volume loop. We can see that on inspiration, the pressure drops, and on expiration, the pressure rises. And this creates the pressure volume loop that has a larger surface area for the TPs compared to the new system. And this surface area represents the work of breathing that is needed to breathe through the system. So the RPAP resuscitation system was tested for delivery room stabilization of extremely preterm infants in a multi-center randomized controlled trial. One of the centers was the Karolinska neonatal unit here in Solna. And in the COSO trial, 250 infants born before 28 weeks gestation were randomized to initial stabilization in the delivery room, either with a new system using nasal prongs or TPs with face mask. And the primary outcome of the study was delivery room intubation or death. And we can see in these graphs that significantly fewer infants in the new system group were intubated or died in the delivery room, and that the difference remained during the follow-up of 72 hours. So the RPAP reduces the need for delivery room intubation in extremely preterm infants, and this creates an opportunity for selective surfactant administration with less invasive methods, and reduces the need for mechanical ventilation during the first days of life. Fortunately, delivery room intubation and death are rare outcomes in infants that are born after 28 weeks. But could stabilization with the new system be of benefit in any other ways to the more mature preterm or term infants? We then started the first trial, that is a clinical feasibility trial on uninterrupted respiratory support with a simplified version of the RPAP resuscitation system for preterm infants in respiratory distress. And our aim was to evaluate if the system can be used to give uninterrupted respiratory support from birth and for the first hours of life, and also if it can be used for stabilization skin to skin. The main differences between the systems include that the T-piece has high imposed work of breathing, and it requires the face mask to be held in place, and that according to studies, this is often complicated by leakage and airway obstruction, and also we need to change to the nasal CPAP before transporting the baby. Both the AirPAP and the simplified AirPAP have low imposed work of breathing. They can be used with either nasal prongs or face mask. And we can fixate the system with a cap, and this enables the system to be used both during stabilization and transport. The AirPAP needs a CPAP driver and 2 tubes for fresh gas flow, while the simplified AirPAP is directly connected to the air-oxygen mixer using 1 tube for the fresh gas flow and another that is connected to the adjustable pressure limiting valve and pressure meter. And if we wish to give positive pressure ventilation, the expiration orifice is occluded with a finger. And here we see the simplified AirPAP setup that enables continued skin-to-skin contact after arrival in the NICU. And our aim was to include newborn infants in need of respiratory support after vaginal delivery at gestational age of 28 plus 0 days to 34 plus 6, or cesarean section up to 37 plus 6. And inclusion required antenatal parental consent, and the exclusion criteria were airway or cardiac malformations, known syndromes or neuromuscular disorders, or anticipated transport to another hospital within 4 hours, as this would interfere with the study period. And the outcome variables include the place of stabilization, the number, course, and duration of interruption of respiratory support, the response to respiratory support, the ease of use, need for rescue with another system, or other adverse events. And these data have not been published yet, but we have now included 32 infants with a gestational age of 30 plus 4 to 35 plus 2 weeks and days, and a birth weight of 1,300 to 4,180 grams. The largest baby was born to a diabetic mother. 17 were born vaginally and 15 with a C-section, and 13 out of 17 infants born vaginally were stable as skin to skin, and the other 4 were moved to a resuscitation table either on the request of the obstetric team at a twin delivery or due to complicated birth and depressed infant. And of course, the safety of both the mother and the infant always comes first. 9 of the infants received any positive pressure ventilation, 5 after C-section and 4 after vaginal birth. And we always have a T-piece and face mask ready for backup, but so far this hasn't been needed. And of course, as this is a feasibility study and not a randomized controlled trial, we will not get any evidence on if this method for stabilization is superior to routine care, only if it's feasible to use the new system for this kind of stabilization and continued respiratory support during transport and skin-to-skin contact. And I will just take you through some of the steps when we stabilize the infant skin-to-skin with the new system. The infant is dried, then we change the wet towels to a warm wool cape and blanket. And the baby is placed in skin to skin, ensuring an open airway. We place the ECG electrodes and the oxygen saturation meter. And we also assess the breathing effort and breathing pattern. And if the baby shows signs of respiratory distress, we place the new system on the infant's nose with the prongs. And we then give CPAP and positive pressure ventilation as needed. And when the baby has stable breathing, we fixate the system with the cap. And of course, it's important to monitor the infant's temperature, making sure it keeps warm. We then place the nasogastric tube and give the first feed skin to skin with the mother. and the baby is transported to the neonatal ward skin to skin, either with the mother if she is ready to leave the delivery room, or otherwise with the other parent. And after C-section, we use the resuscitation table for the initial stabilization. This baby has the system in place and the nasogastric tube and is receiving the first feed. The baby was then transported to the neonatal department skin to skin with the father, where the infant got continued respiratory support with heated humidified gases, and we continue monitoring the infant and giving feeds. So I would like to finish by quoting the European RDS guidelines that I think summarize many of the things I have been talking about. And I will read to you. European resuscitation guidelines cover protocols for when and how to intervene in infants who are born in poor condition secondary to hypoxia, with emphasis on airway opening and aeration of the lungs using positive pressure. A separate approach is needed for most preterm infants at risk of RDS, as they are not asphyxiated and with time will try to breathe on their own. And supporting normal transition with more gentle interventions is preferable. Deferring cord clamping, allowing time for placental transfusion and establishing lung aeration before clamping will lead to a better hemodynamic transition. For spontaneously breathing infants, CPAP initiation rather than intubation will reduce lung injury and BPD. TPs devices allowing careful control of peak inspiratory pressures and PEEP are considered better than self-inflating bags. The interface between the CPAP device and the baby may also be important. Face mask application on its own may be sufficient to induce apnea via the trigeminal cardiac reflex in spontaneously breathing infants, and nasal interfaces offer an alternative method for CPAP provision at birth. Heating and humidification of gases used for stabilization is ideal in terms of preventing heat loss. And I think that with the evidence from, among other, the immediate skin-to-skin study and my experience from the first trial, we can adhere to these guidelines while the infant is skin to skin with the mother in very many of cases, at least for the very preterm infants. For now, I have no experience for the extremely preterm infants. And I would just like to finish with this photo. This is little Jack that was born in week 25. Although he was not stabilized skin to skin, he has been receiving skin-to-skin contact with his parents, first when he was on the mechanical ventilation, then CPAP for many weeks, and there the high-flow nasal cannula. And I would like to acknowledge the other research group members of my group, and thank you all for listening.
Thank you very much, Sonja. Any questions for Sonja? Has there been what has been the obstacles about this study?
The largest obstacle has been to include the patients when we need the antenatal parental consent.
Okay.
And when we don't know when the babies will be born, so we require a lot of consents for few babies being included. But all the parents that we have talked to before inclusion have been very enthusiastic, and most have wanted to be in the study.
That's fantastic. Is there any question? I don't know. I haven't seen it. Yeah. So we continue. Thank you very much again, Sonja.